I'm Peter Block in Chicago at ACC 2016 for On the Scene, and with me is Eric Velasquez from Duke. Eric has just finished talking about the STICHES trial, and although we have a lot of trials that are sort of ambivalent, negative, oh ho hum, this is not an oh hum trial. So Eric, tell me about STICHES.
Thank you. Well, STICHES was a trial that looked at the incremental effect of CABG on top of best medical therapy in patients with ischemic cardiomyopathy. We defined those patients as those with severe LV dysfunction and EF less than 35%, who have coronary disease and are eligible for medical therapy. So they have to have the absence of left main stenosis and the absence of disabling angina that can't be treated medically. So that's the population we randomized: 1,212, 610 to CABG, 602 to medical therapy. Followed them up for 9.8 years on maximum, every 6 months, 98% complete follow-up, so we're very proud of that, and to our investigators, and we're able to provide a very definitive answer.
Okay, so I guess we'll pop right to that. Tell me what you found.
We found that CABG led to a 16% relative risk reduction in mortality. That translates to about an 8% absolute risk reduction and about an 18 months extension of survival, median survival among these patients. A number needed to treat to prevent one death of about 14. And then we had other key secondary endpoints like cardiovascular deaths, where we saw similar direction, 21% risk reduction, 9% absolute risk reduction, number needed to treat of about 11. And every endpoint we looked at, it was quite consistent, statistically robust, directionally similar in favor of CABG. So I think we have now the evidence base to be quite clear about our recommendations.
So, you know, Eric, I'm having a deja vu all over again, right? The CAS trial in the late 1970s asked this same question. We were not sophisticated back then as we are now, and certainly didn't have as many hooks into how to do a good clinical trial, so obviously much less information. But CAS showed that if you had a bad left ventricle, you did better with surgery than you did with medical therapy. Would you agree with that? And would you say this is an extension of or support of, or the CAS supports your trial? What would you say?
I think CAS started the concept, and it introduced the concept, an important one, that the higher the risk, the more the benefit. What I would say that's different clearly is that CAS excluded patients who had an EF less than 35%. Only 4% had heart failure. We had 90% with clinical heart failure, class 2 or greater. And they only enrolled 160 patients, and medical therapy at that time, 25% were on aspirin only, and there was no statins, no ACE inhibitors, no beta blockers. And the LEMA, which I think is an important thing we probably do need to mention, was only used in about 9%, while we had a 91% use of the LEMA. So I think what we've done is updated, what they did was introduce the concept of the worse the extent of your disease, the better you might have a benefit of CABG. I think we've clarified it in the most extensive heart disease patients.
Couldn't agree with you more. I think your very sophisticated trial now shows us that, hey, it's good for the myocardium to have blood flow. And if you have a bad ventricle and are a high risk, get a coronary bypass graft. Thank you very much, Eric.
Thank you.